All right, welcome everybody to the board review. So sorry for the delay. We did do this review live in person and it was actually delivered by Dr. Wong on campus. Understandably, many of you are out on preceptor and we wanted to make this available to you. Unfortunately, the recording was a fairly poor quality in terms of the contrast with the live recording. So I did want to take some time to re-record this and make it available to you. This is Dr. Motley, and I'm so happy to go through a couple of topics with you. We will cover trauma, arthritides, and metabolic conditions. And the first thing we'll cover is trauma. So there's a bunch of different fracture varieties. Some are very specific to regions of the body. So for example, Osgood-Schlatters, which is more of a micro-traumatic injury, is specific to the knee. Same thing with upper extremity, many very specific fracture types. We'll go through some dislocations, fractures of the spine, and then some miscellaneous injuries. So let's just jump right into it. I wanted to remind you for a moment about the Dennis's three spinal columns or three column theory of stability. And this really boils down to fractures involving the spine. Instability is something that can be caused by trauma naturally. There's other causes of instability. So you think about like degenerative instability, for example, or instability created by maybe ligamentous laxity and a connective tissue disorder. In either case, the concept of instability in this discussion is really specific to trauma, and Dennis's spinal columns allows you to assess based on the columns involved in the fracture pattern whether or not it's unstable. So here's a really nice illustration from our DAC friend, Dr. Matt Skowski, outlining the three columns of the spine from a lateral perspective. So the anterior column runs from the anterior longitudinal ligament, illustrated in light blue, to kind of the mid to 2/3 of the vertebral body. The very posterior aspect of the vertebral body, along with the posterior longitudinal ligament, is the middle column. So anterior column goes from ALL all the way to the kind of posterior aspect, mid to posterior aspect of the vertebral body. And then from the posterior vertebral body to the PLL is the middle column. And then all the rest is considered posterior column, basically from the pedicles all the way back to the supraspinous ligament. So we think about, for example, compression fractures, the most common fracture pattern in the spine. Compression fractures really just cause anterior vertebral body wedging. And in the case of compression fractures, the posterior vertebral body height is maintained. Since only a single column is involved in compression fractures, they're considered a stable pattern of fracture. Dennis's three-column theory suggests that if two or more columns are involved in a fracture pattern, that the fracture pattern is inherently unstable. So let's take, for example, a burst fracture. A burst fracture is a comminuted vertebral body fracture, basically fracture all through the vertebral body, decreasing the anterior and posterior vertebral body heights respectively, often causing retropulsion into the spinal canal. And burst fractures, because they involve two columns of the spine, maybe even three, at times it's considered an unstable fracture pattern. So the significance of Dennis's spinal columns is really to help you assess whether or not a fracture is considered unstable based on the parts involved. We take, for example, as the last example, a clay shoveler's fracture, an avulsion of the spinous process. Clay shoveler's fractures only involve one column, the posterior column, and therefore are considered stable fracture patterns. Here's an example of a clay shoveler's fracture. So frontal and lateral views of the cervical spine in a patient who had some trauma. And you'll notice there's some sort of stabilization device here. You can see there's some sort of artifact in the background here. And typically in the board, you're going to get some sort of question associated with the film. So it's going to ask you about a diagnosis or give you a scenario, ask you about, the follow-up or the recommendation. And so when you're looking at the cases, particularly for the diagnostic imaging portion, you want to put it all in context based on the patient's history, based on their presentation, the images that you're looking at, and the findings that you see. Make some decisions about what's going on with the patient. You'll notice on the lateral view, and this is true for all Clay-Shevler's fracture, most easily seen from the lateral perspective, and you'll note the, let's see, 1, 2, 3, 4, 5, 6, 7. The C7 spinous process is fractured, and it usually fractures along the distal third or so. You'll see the spinal laminar junction is quite proximal to that fracture site. The biggest thing with Clay-Shevler's fractures is they always go non-union, so you don't expect them to reattach through healing. This seems to be a acute fracture, but even in old fractures, the fragment will not be attached. There is a name sign associated with this Clay-Shevler's fracture, also known as root puller's fracture or coal miner's fracture. Those are the AKAs for this: root puller, coal miner, and obviously Clay-Shevler. And you'll note the double spinous process. The name sign is the double spinous process sign, wherein you'll note on the frontal projection the spinous that naturally occurred, and then much lower than that, well, not much lower, but adjacent, the portion of the spinous that's fractured off and inferiorly displaced. So from a frontal perspective, you'll perceive two spinous processes as outlined here. All right, next, Hangman's fracture. Now, Hangman's fracture is unique to the cervical spine, and it's really defined as a bilateral pedicle fracture. And the pedicles of C2 are nicely seen radiographically on lateral views. You'll note the lateral cervical projection off to the left, and as we note here in the neural arch, kind of vertebral body junction, there's a fracture through the pedicle region. The CT examination, this is an axial slice in the center. You'll note the fracture bilaterally through that vertebral body pedicle region. So here's the vertebral body, here's the pedicle, and you'll note the pedicle fractured kind of near the articular pillar junction. And we can appreciate that from a sagittal perspective. So here's the occipital condyle of C0, here's the lateral mass of C1, here's part of the pedicle, here's the back of the body of C2, and then here's the pedicle of C2 fractured just proximal to the articular pillar. And this would be present on the other side also. Usually with these, there's an anterolisthesis of C2. I'll remind you, and let me just remove these annotations so you can see that there's no anterolisthesis that's really dramatic in this case, but Hangman's fractures are also known as what is it? Gosh, I can't even think. I'm recording this at 8:30 p.m. But traumatic spondylolisthesis of C2 is a name often given as an AKA to Clay-Shevler's fracture. So traumatic spondylolisthesis, meaning there's a fracture in a non-pars location leading to a slippage. Hangman's fracture, usually caused by hyperextension, and of course fractures should go to the hospital, effectively spinal fractures. Now, with Hangman's fractures, this is not considered an unstable fracture pattern because only one column is involved, and that is the posterior column, where the margin of the posterior column starts at the pedicles. So this is not an unstable fracture pattern. However, it is a spinal fracture, so a patient would be immobilized and sent to the hospital for some sort of bracing through management. Another common fracture pattern in the cervical spine, particularly at C1, is the Jefferson's fracture. Now, C1 really only fractures in one of two ways. This way, Jefferson's fracture, and then isolated posterior arch fractures. And the only difference really between the two is that isolated posterior arch fractures are often caused by hyperextension, whereas Jefferson's fractures are caused by an axial load, generally to the skull. So you think about a rollover car accident, or in the case of living in upstate New York, a bale of hay falling on a farmer's head, right, creating a spreading effect of the lateral masses from the forces of the condyles of C0 passing through them. Remember, the major finding in Jefferson's fracture is spreading of the lateral masses. So here's the lateral margin of C1, and here's the lateral margin of C2, and these should line up with each other. So you can tell on both sides that the lateral margin of C1, seen here, fails to line up with the lateral margin of C2. Effectively, the lateral masses should live in the same plane as the lateral portion of C2. So these are overhanging lateral masses, abnormal atlantoaxial alignment. And the reason why the lateral masses are spread out is because there's a fracture on both the anterior and posterior portions of the arch, spreading the lateral masses farther away from each other, and also increasing what we call the paraodontoid space. Remember the paraodontoid space on an AP open mouth, para next to odontoid, the space next to the odontoid. So there's the dens. Here's the medial margin of the lateral masses, and we can assess the paraodontoid spaces here. You'll notice they're not equidistant. Usually, there's no minimal kind of measurement, but they should be equidistant, so the same distance on either side. And then collectively, in the face of fracture, they should not exceed 8 millimeters combined. If we look at this space, periodontoid space 1, and add it to periodontoid space 2, anything in excess of 8 millimeters is suggestive of transverse ligament rupture. And remember, the transverse ligament kind of attaches in this perspective. So very often when atlas breaks, the transverse ligament can be torn. And that's something to look for. So patients with Jefferson fractures typically don't have neurologic injury because of the spreading of the osseous structures. However, it is considered a fracture pattern that can have ligamentous changes to the ligaments, particularly transverse ligament, causing instability in the long haul. Now, Dens fractures are another common fracture pattern, in this case at C2. So you think about common fractures at C1, Jefferson's fracture, and isolated posterior arch fracture. We didn't show an example of isolated posterior arch. But then C2 fractures common are the Hangman's that we already went through, and this one, Dens fractures. Now, I remind you that the Dens can fracture in one of 3 locations. At the very superior margin of the dens, this is considered stable because it's above the level of the transverse ligament. The really worrisome type is type 2, which fractures at the dens base. And this is unstable because the fracture occurs below the level of the transverse ligament, and the dens is effectively going to move with C1 and it'll be no longer attached to C2. So this is an unstable fracture pattern, type 2. It's also the most common pattern. So of all Dens fractures, the type 2 variety is most common. It is worrisome. It's unstable. For 1, neurologic injury can occur. And for 2, non-union occurs at a pretty high rate here as a complication. You'll note type 3 fractures are well into the body of C2, and these are usually stable because of the capsular ligaments when the lateral mass articulates with C2. So the most worrisome variety is the type 2, unstable, and can undergo non-union. These patients need an emergency transport to the hospital with immobilization based on the risk of neurologic injury. These are usually patients that violently hyperextend. So you think about like a face plant type of fall can commonly fracture the dens in this pattern. You'll notice on the radiograph a discontinuity along the margin of the dens. As we get about here, you'll note a lucency crossing the dens. You'll note just a general lucency in this region, and also some evidence of comminution. Now, if you're not sure, the next best test to order is a CT examination. Whenever we're not sure about osseous findings, computed tomography is really the best way to go. All right, now moving on to the next fracture pattern. This is one of the few fracture patterns that has 2 mechanisms of injury. One is hyperflexion and the other is hyperextension. So let's start in the image off to the left. This is a radiographic examination, lateral view, in a patient who likely had a hyperextension-based injury. And you'll notice a triangular or teardrop-shaped fracture off the anterior inferior corner of C2. Now, teardrop fractures can happen at any level. In this case, it just happens to be C2, but the fragment is always triangular off the inferior corner. Now, these are less severe than the hyperflexion variety of this injury. So in the image off to the right, you'll note that this patient also has a large triangular fragment fractured off the body of, in this case, the C4 vertebrae. But you'll note here there's a lot more going on. There's a quite angular kyphosis occurring here at the cervical spine. You'll also notice the splaying of the spinous processes, the widened interfacetal space here. This is a sign that the anterior column of the spine was fractured, and also that there's some ligamentous damage in the posterior column of the spine. Often these cases come with neurologic injury because remember the cord transverses through this area, and these patients are considered unstable. In contrast to the hyperextension teardrop off to the left, patients are generally considered stable. So if you're posed with a spinal fracture in boards, there's only a few that are non-worrisome, like the clay shovelers, TP fractures, compression fractures. But if you get hit with a much, more severe fracture pattern, then always consider referrals, being immobilization, and transport. It's really about assessing what aspects of the bone is actually fractured. Now, I wanted to talk a moment about spondylolisthesis, and it's really only one sub-variety of spondylolisthesis that's appropriate for this particular discussion. Well, maybe two, but it's really the stress fracture-based slippage and the acute fracture-based slippage. So what you're noting here are the 5 different types or causes of spondylolisthesis. And we'll want to pay very special attention to the type 2 variety, in which there's type 2A, type 2B, and type 2C. These are described as the isthmic variety. Now, an isthmus is a narrow attachment point for something, okay? Like the isthmus of North and South America connecting at like the Panama Canal, for example. The isthmus is the pars interarticularis. And so the isthmus type of spondylolisthesis occurs with problems at the pars. So you'll notice the subtype A, which we're also familiar with, is the stress fracture at the pars, generally leading to an anterolisthesis. Scotty the dog's wearing a collar, typically young, athletic, really active individuals, often hyperextending. And then you have the type 2B variety, which is basically an elongated pars, but it's intact. It's just too long, so the space between the superior and inferior articular process is far away, and this kind of leads inherently to an anterolisthesis. And then the very rare type 2 variety, described as C, is the acute fracture at the pars, which is very unusual. And so these are the 3 subtypes of the isthmic variety of spondylolisthesis. Now, I'll remind you that patients can have pars defects, like in the case of a stress fracture, an old stress fracture that never healed, we'd call a pars defect. Patients could have defects without slippage. And based on the fact that there's other causes of slippage, a patient can have slippage without a pars defect. The other causes of slippage include the dysplastic type of spondylolisthesis, which is all about congenital anomaly to the vertebral body leading to slippage, things like spina bifida occulta, for example. Type 3 spondylolistheses are degenerative, caused by osteoarthritis, either at the disc and or the facet joints. Type 4 slippages are caused by fractures at non-pars locations. So in this illustration, they're showing a fracture at the pedicle as the cause of the anterolisthesis. And then pathologic fracture is type 5. There's also a type 6 that's been added, which is the iatrogenic type. Patient has a spinal decompression or some sort of surgical intervention, and now the patient has slippage in the spine. So these are the different types of spondylolisthesis. Now remember, the term spondylolisthesis is non-directional specific. So anterolisthesis is better to say than spondylolisthesis, retrolisthesis, laterolisthesis. And these are all kind of directional specific so that the reader of the report or the listener of the description will be sure of what direction. But these are the different types of spondylolisthesis. So here's an example of a patient who has spondylolysis. And let's start with the case off to the right because this is a very obvious spondylolysis case. Now, generally speaking, spondylolysis is most common at L5, followed by L4, and so on and so forth. The easiest thing to do, and let's just start at the normal vertebrae. The easiest thing to do is follow the vertebral end plates to the posterior aspect of the vertebral body, and the next natural structure is the pedicle, followed by the articular pillar. Now, the articular pillar in the lumbar spine is very long. Here's the superior articular process. Here's the inferior articular process, and this is the point of connection between them. So when you're looking for a pars interarticularis defect, follow the pedicles back, identify the superior articular process, identify the inferior articular process, and if there's a break between them, there's spondylolysis at that level. You'll notice when we come down to this vertebrae, and I say this one because it's hard to tell, is this the sacrum? Probably. This is probably L5 here. It's probably L4. But you'll notice the pedicle, superior articular process, inferior articular process is all the way over here, and then the pars defect. Realize that you don't always need lateral obliques to see spondylolysis. Okay. Again, these typically happen in young adults who are very active, hyperextend. You'll notice these spondylolyses are very smooth and very regular. These are old. These are not new pars defects. These are not active stress fractures. And if you're not sure, MRI is the best way to go. So let's say you get a case of a young male with low back pain. You see some kind of hazy appearance at the pars. You suspect a defect. Maybe you see a little lucency, but you're not sure. Rest, conservative management, and an MRI is most useful. If there's bone marrow edema, it's still active. Leave it alone. They need to rest. The image off to the left here is a good example of degenerative spondylolistheses. So you'll notice in this case, when we follow the pedicle margins back, the superior and inferior articular processes are connected at every level. The pars is intact, L5, L4, here's the pars of L3, here's the pars of L2, here's the pars of L1. All these structures are intact, and we see these anterolistheses. So we're thinking, how is this possible? You'll note the intervertebral disc degeneration. I've kind of covered up the facet degeneration associated with these levels, but facet joint, hypertrophy and sclerosis, perfect sign of degeneration. This patient has degenerative anterolistheses. Now, really quick before I move on, and I know I'm a little long-winded through these discussions, but I really want you guys to understand this information. Remember, when you name spondylolistheses, you come to the break in George's line first. So all these, vertebrae are properly aligned. And now we come to a break in George's line. This break is between 5, 4, 3. So this is between 3 and 4. We always name the upper vertebrae's position upon the lower. So there is a anterolisthesis of L3 upon L4. Now you notice there's another break in George's line at the next level. Now we're going to name the position of the L4 vertebrae upon L5. L4 is also anterolisthesed relative to L5. All right, now here's an example of polytrauma. Well, it's probably a single trauma, but there's multiple findings here, and that's really a tribute to not being satisfied with your search. So when you go through films, it's really important to look at all the images and also to just assess all the anatomy. In this particular case, the patient had some sort of hyperextensive trauma to the wrist, most likely based on what's going on here. And when we talk about the arcs of carpal alignment, they are abnormal here. Now remember, there's two carpal rows, proximal row, distal row. The arcs of carpal alignment of Galula, actually, they're named after someone named Galula. The first arc is drawn along the proximal aspect of the proximal carpal cortices. You'll notice the scaphoid and the lunate line up fairly well proximally, but the triquetrum's a little inferiorly or proximally malpositioned. The second arc of carpal alignment goes along the distal aspect of that proximal carpal row, and this should make a smooth arcing line. It's not. There's a break in the second arc of carpal alignment. I apologize, my mouse is a little sensitive here. This suggests that the carpals are not in the proper position. The third arc of carpal alignment is along the proximal aspect of the capitate and hamate. Now, when we go to look at the carpal alignment from the lateral perspective, the most important thing is to find the stack of the lunate followed by the capitate. So when you look at carpals from a lateral perspective, the lunate should be sitting in a U-shaped position and the capitate should sit on top of it. And then of course the scaphoid kind of peeks its nose out, right, in the ventral side. When we look at this wrist from a lateral perspective, here's the lunate. This little teacup or half moon looking structure should be in a U-shaped position. In this case, the teacup is spilling forward or ventral. We can tell this is the first metacarpal folded over with lateral hand positioning and wrist positioning. So this lunate is ventrally displaced. When we look back in retrospect to the P to A view, we can tell that the lunate is in a triangular position. This is a lunate dislocation. Pi sign is something that we should consider, or the name sign associated with this. All right, now here's a patient who has a very classic shoulder injury, and I'll remind you about different shoulder injuries. So the two kind of important joints in the shoulder are the acromioclavicular and the glenohumeral articulation. In this case, the glenohumeral articulation is misaligned. Now, when we think about alignment of the AC joint, we always look at the undersurface of the AC joint because sometimes the clavicle's taller, than the acromion. In this case, patients got like osteophytes growing, so we always look at the undersurface. The alignment of the acromioclavicular joint here is normal. But when we look at the glenohumeral joint, we'll notice that here's the glenoid and its articular surface. And here's the articular surface of the humeral head. These couldn't possibly be articulating with each other. Here's an example of a glenohumeral dislocation. Now remember, just based on stats, 95 to 97% of humeral dislocations go anterior. And they have that inferior and medial kind of coupled malposition, right? The humeral head sits kind of below its normal position and more medial than it should, as in this case. This is an anterior dislocation. Posterior dislocations are a lot less common, somewhere between 1 and 3% of shoulder dislocations. And remember, the posterior dislocation doesn't give you as much malposition. The humeral head appears a little too medial on the glenoid, but not a dramatic superior-inferior malposition, a little medial malposition as well. In either case of dislocation of the shoulder, you can always fracture either the humeral head and or the glenoid in the case of these injuries. Now, in the cross-sectional CT off to the right on the same patient, you can appreciate that the humeral head has a posterolateral defect on it. Little hatchet, also known as Hill-Sachs defect, which is an impaction fracture that occurs on the humeral head with anterior dislocations. The glenoid side injury, if present, not seen in this case, is called Bankart. Remember, when posterior dislocations happen, not seen here, patients can have a reverse Hill-Sachs or a reverse Bankart, which is the same type of humeral or glenoid injury, respectively, but at a different anatomical location on those structures based on the point of impact of posterior dislocations, humeral head and glenoid impact. Excuse me. All right, now at the hip, the opposite is true. At the hip, posterior dislocations are a lot more common. 85% of femoral acetabular dislocations go in a posterior direction, and these are usually from motor vehicle collisions, but there can be numerous, mechanisms of injury. But at the basis of it, a P to A kind of drive a force of the femur in the acetabulum. The big thing with posterior dislocations is they kind of go up and out. So you'll notice this humeral head is not living within the acetabulum. Definitely a dislocation of the right femoral acetabular joint here. And one of the biggest concerns is whether or not the acetabulum is fractured. Remember, in 90% of posterior hip dislocations, the acetabular rim fractures. They call these dashboard injuries, and they're often very difficult to see. In the image off to the right, this patient actually has a really good example of a dashboard fracture. In a normal situation, and let's just use the other kind of normal side here, you see the acetabular base, but you can also see the acetabular rim. When we look on the other side, we see the base of the acetabulum, but you'll notice there's a large defect here along the margin. And then there's an osseous fragment here. So this patient actually fractured off the posterior rim, and it's been displaced superiorly along with an actively dislocated femoral head. The easiest way to tell there's a dislocation is when the articular surfaces are not touching. Anterior dislocations in the pelvis are a lot less common. 15% of glenohumeral dislocations occur in a ventral position. In that case, the femoral head would sit somewhere over here. So inferior and medial, the exact opposite malposition than with posterior dislocations. All right, now Salter-Harris injury. This is all about the pediatric patient. Salter-Harris, I'll remind you, classifies injuries occurring in and around the growth plate. What's illustrated here is the metaphyseal epiphyseal junction of some long bone and the cartilaginous growth plate that occurs in between. In type 1 injuries, it's a translational malposition of the epiphysis upon the metaphysis. So they effectively fracture along the growth plate, and generally the epiphysis and the growth plate will be malpositioned in a translational way. So you imagine slipped capital femoral epiphysis, for example, where the femoral head is not in the right spot on the femoral neck. The most common variety, however, is the type 2 Salter-Harris injury, in which they fracture through and along the growth plate and up and through the metaphysis as well. So they end up with a little triangular fragment of bone that's attached to the epiphysis and the growth plate in general. This fragment is called the Thurston-Holland fragment. And this is within the type 2 variety that is the most common. So you'll think about this as above, right, straight through for type 1, above meaning above the growth plate into the metaphyseal region. And then type 3 growth plate injuries occur through that growth plate margin and down through the epiphysis. Now, type 3 is bad because remember there's articular cartilage that lives on the epiphysis. So generally in these fracture patterns, the articular cartilage is damaged. This has a worse prognosis than the type 2 variety. Usually the articular surface is injured, and sometimes early growth plate fusion can occur. Type 4 is pretty bad also, which goes through all three, metaphysis, growth plate, and epiphysis. Bad for all the imaginable reasons, including the fact that there's articular extension of the fracture. These patients will end up with a lipohemarthrosis, right? Fat and blood in the joint. as well as some chondral injury and just a worse prognosis than the other types. And then type 5 is a crush injury. And these are notoriously hard to detect when they happen. Usually it's stunted growth assessed or identified later that suggests that it was fractured in the first place. So early growth plate fusion is usually seen with type 5 variety. So remember, type 2 is the most common. It's the only one that has a little name sign for the Thurston-Holland fragment, the metaphyseal fragment, seen in type 2 growth plate injuries. So anywhere there's a growth plate, this pattern of fracture can occur. So here's an example of the classic type 1 growth plate injury. Slippage off to the left, you'll notice the A to P view of the pelvis and a patient who has a positive Klein's line off to the patient's left side. This is the left side of the patient, right side of the patient. Klein's line, remember, is drawn along the lateral aspect of the femoral neck, and you should normally have overlap of the epiphysis with the line. You'll notice in the involved side, we draw a Klein's line, and there's no intersection of the epiphysis with the line. So this is a positive Klein's line on the patient's left, indicative of slipped capital femoral epiphysis. Now we look in the, kind of jump over to the image to the far right here, you'll notice that there's epiphysiolysis. This is a term that we use to describe type 1 injuries, as we've seen in the image to the far left. In this A to P view of the shoulder, you'll notice the epiphysis is just completely detached from the metaphysis here. Like literally the cap of the humerus is in the wrong spot. This is a type 2 injury. If we look at the kind of center image, AP image here, it looks like there's a fracture through the growth plate. I apologize for the kind of blurry image, but really it's all about where the fracture goes through. So if it goes through the epiphysis only and through the growth plate, then that's a type 3 injury. If it only goes up through the metaphysis, type 2 injury, right? And so this is how you think about growth plate injuries. And the image all the way to the far right, this is a coronal slice through the ankle. So here's the distal tibia. Here's the tibial growth plate. And then you'll notice the medial malleolus is fractured through that epiphyseal region. And it looks like some of the growth plate is involved too. So this would be considered a type 3 injury as well. Oh, this one must have gone all the way through. This was type 4. Kind of see lucency on both sides. All right, now let's talk for a moment about osteochondral injuries. Now remember osteochondritis, sorry, I just had to take a quick break and make sure I was still recording. When you do, I'm using a program called Camtasia, which is kind of a screen capture software, but just wanted to make sure I was actually being captured so that I'm not lecturing, with no result. But we were just going to pick up with osteochondritis dissecans, for short, often referred to as OCD. And this is a condition really of articular cartilage and often the underlying bone. So hence the name osteo for bone and chondro for cartilage, itis, inflammation, dissecans to kind of dehydrate and essentially fragment. So here's 3 separate patients, all of whom have articular surface defects. Now think about this. Radiographically, we can see the epiphysis, the extreme ends of the long bone, but we cannot see the articular cartilage that overlies it. So sometimes in osteochondritis dissecans, there's only a chondral component and we can't see it radiographically. MRI would be the modality of choice to assess chondral-based osteochondritis dissecans. Excuse me. In the image to the far left, you'll notice that it's a osseous and associated cartilaginous fragment that we can't see. So anytime the articular bone is involved, you know that the cartilage that lives on top of it is involved as well. The most common location is in the knee, as in the case you're viewing to the far left. Usually it's pediatric patients. The lateral aspect of the medial femoral condyle is most common, as you see here. And so you'll notice this osseous defect along the femoral condyles that's kind of semicircular in configuration. And this particular this particular fragment is still in situ. That means it's still in its original location. It hasn't broken off to float around. But in the case that it did, we'd call it a loose body. So osteochondritis dissecans is very commonly leading to loose bodies in the joint when the fragment migrates away from its original location. At that point, we'd call it an osteochondral defect on the femur and be looking for the osteochondral fragment from which it came from the condyle. Here's a cross-sectional image of the knee, coronal slice. This is some sort of fluid-weighted sequence, so a T2 weighted fat sat, or a stir image. And you'll notice along the infero kind of, I don't know, we'll call this midline. I suspect this is the lateral aspect of the knee just based on the anatomy. But you'll note the osteochondral injury occurring in this semicircular configuration, isolating a piece of bone and cartilage that has not floated away in this case. So you're really looking for articular defects. You'll notice on the other side, the articular cartilage is very smooth on both the femur and tibia, and then you'll notice this fibrocartilaginous meniscus, really low signal as expected. These are normal as well. The image all the way to the right, you'll notice the talar dome along the lateral aspect, medial aspect. This is the tibia, has some kind of hyperlucent appearance to the articular surface with a barely perceptible semicircular lucency. This is another case of osteochondritis dissecans. Now let's talk for a moment about Scheuermann's disease. This is a condition known as apophysitis. Remember, the vertebral bodies are still growing when we're in adolescence, and they do have vertebral end plates, which are the apophyses or the secondary growth centers for the vertebral bodies. And in the case of Scheuermann's disease, those end plates are inflamed. So vertebral apophysitis is really the best way to describe Scheuermann's. As a result of the inflammation and hyperemia, the end plates get weaker and Schmorl's nodes occur, along with anterior vertebral body wedging. So the most characteristic findings of Scheuermann's are those two things, Schmorl's nodes and anterior vertebral body wedging. You can see multiple vertebrae have this kind of anterior height loss. This produces a general hyperkyphosis, which is very commonly seen in adolescent males. At least this condition is seen in. So Scheuermann's disease is a self-resolving condition, but can cause pain, spinal deformity, and really conservative management is the way to go. Now, AC joint separation, and this is kind of, a little out of order in terms of like where we are in the discussion. I'd argue that glenohumeral dislocations and acromioclavicular joint dislocations happen with very similar kind of mechanisms of injury, usually a fall, or in the case of a dislocation, a throw, or some sort of kind of end range malposition for the joint. AC joint separations are really kind of graded based on their radiographic findings of malposition of the clavicle relative to the acromion. And this is a little illustration I put together just to show what we can expect to see in the different grades of AC joint separation. So first of all, let's identify the fact that there are 6 grades. Types 4, 5, and 6 we don't really talk much about because they're really subcategories of 3, wherein all the ligaments are torn that support the AC joint. So it's really 2 ligaments of interest. First ligament is the acromioclavicular ligament, and the other ligament is the coracoclavicular ligament, which has 2 bands to it. In the case of type 1 AC joint separations, the AC ligament is sprained, hence the dotted lines here, and the coracoclavicular ligament's intact. So what this means is that radiographically, the joint is likely aligned. Remember, we always look at the undersurface of the clavicle up against the undersurface of the acromion. So grade 1 AC joint separations generally have no findings. Maybe you can see a little widening of the joint space. They'll definitely be clinically symptomatic. But if you see a normal radiograph, it does not rule out a type 1 injury. Remember, weighting is always useful. You distract the shoulder with a second view and see if a misalignment appears. Now, in type 2 injuries, the AC joint, the AC ligament is completely torn, and the corticoclavicular ligament is sprained. And as a result, the clavicle partially elevates relative to the acromion. And I didn't draw that in here, I apologize. But typically there's going to be some elevation of the clavicle relative to the acromion, but not totally dislocated. There'll still be articular surface, kind of contact between the two. And we expect partial misalignment, whether with weighting or unweighted. Type 3 injuries, both the AC and corticoclavicular ligaments are completely torn. The clavicle completely elevates relative to the acromion, does not align at all, and this is indicative of a grade 3 injury. Now, the cutoff point is really between grade 2 and grade 3 because grade 2s and lower are conservatively managed, rest, ice, some time to recover. Type 3 and up are surgical repairs. And so if there's a type 3 injury or worse, an orthopedic consultation is necessary. If the presentation is a grade 1 or grade 2, you can manage it chiropractically. Type 4 dislocations are posterior dislocations. So basically the clavicle goes posterior. Type 5 is gross superior elevation, like way up there. And type 6 is generally subcoracoid or intrathoracic malposition of the clavicle. So these are more severe injuries, of course. And all of those 3 through 6 are surgical. So here's an example of an AC joint separation. Let's start with the one off to the left. The best thing we can do for ourselves is assess the undersurface alignment of the acromion and the clavicle. And you'll notice partial elevation of the clavicle relative to the acromion. Okay. In the image off to the right, you'll notice complete elevation of the clavicle relative to the acromion. So the image off to the left, this is a grade 2 injury. Image off to the right is a grade 3 injury. Grade 2, conservatively managed. Well, in this case, the patient has a scapular fracture also. So they're off to ortho, of course. But in the absence of any fracture or dislocation, this is what we'd expect. And then image to the right is definitely a grade 3 separation, orthopedic consultation. All right, now let's talk for a moment about scoliosis. There's a few things to consider. One is that chiropractically, we really need to just establish that it's not a worrisome type of scoliosis. And what I mean by worrisome type is types that are caused by something going on, like a congenital anomaly. A patient's got a hemivertebra, patient's got a fused segment, and this creating this structural scoliosis. Those will never resolve, right? Those are structural and will be there. We don't expect them to increase in dimension or decrease in dimension. Other things we have to consider is patients who have scoliosis due to central nervous system issues like a tethered cord, a syrinx in the cord, Chiari malformation. These are considered neuropathic types of congenital scoliosis. So maybe the patient has neurologic defects, maybe they have balance issues, some indication that it's a non-idiopathic case. Patients with skeletal dysplasias, you'll often note other findings. Same thing with these other types of scolioses. So the type that's most manageable for us and most common in the adolescent group is the idiopathic type. And typically we're dealing with an adolescent idiopathic type. Infantile and juvenile scolioses have a much higher incidence of being non-idiopathic. So like if you see scoliosis in a baby, for example, they need to be worked up for some, to find the cause, because idiopathic scoliosis in an infant is not as high of incidence as it is in an adolescent population. Patients have things like torticollis, for example, from birth and can have scoliosis. But in other cases, they have a meningocele or a Chiari malformation. And so when there's really young kids, really less than 10 years old, we should be concerned. One of the important things is that most adolescent scolioses are right convex in the thoracic spine. Remember, dextro is right, levo is left. So right-sided thoracic scoliosis with a female predominance is key with scoliosis. Here's a patient who is being assessed for scoliosis, a few different patients. And you'll notice in the image to the left, the patient has a pretty dramatic right thoracic, right, coronal plane curvature. Sometimes these are taken P to A to reduce gonadal dose and also just to kind of conform to the natural curvatures of the spine. These are generally young patients. Remember Reiser sign. Reiser sign is ossification of the iliac apophysis, and this patient has a very early Reiser sign, which means that they're not that close to skeletal maturation. And so what this means for patient care is that you need to kind of monitor their scoliosis until they reach a Reiser grade 5, which is, well, really Reiser grade 4, which is complete coverage, and then following Reiser grade 5, which is fusion of the iliac apophysis to the ilium. And so, of course, there's two ways to measure scoliosis, the Reiser-Ferguson, and then the actually preferred Cobb's method. And Cobb's just takes the uppermost end plate, right, the lowest most end plate, and take them out into an oblivion, and then we measure the angle occurring between them. Usually they'll drop a perpendicular and measure the acute angle. Cobb's method uses a third landmark, and so the reliability isn't as great. Here's another patient with a really dramatic right convex thoracic scoliosis. So idiopathic ones will be free of any congenital anomalies, free of any, underlying causes. In the next image, kind of the third image off to the right here, you'll notice that this patient has more of kind of an angular deformity. You'll notice that it's a left convex curvature. And you'll also notice that they have some kind of interesting rib stuff going on here too. Like notice how much space is occurring between these two ribs, which is really the area between the anomaly zone here. And you can tell there's kind of a cluster of osseous abnormality here. This is a perfect patient who should get a CT examination to figure out exactly what type of anomalous development is happening in their spine. Turns out this patient has a butterfly vertebrae up top and a hemivertebrae followed by kind of an oddly shaped vertebrae. And these are responsible for the acute left-sided or levoconvex thoracic scoliosis. So this patient has structural scoliosis. Adjusting is not going to help correct their curvature. It may provide them with symptomatic relief, of course, but in terms of management, they're really limited in their spinal alignment-based prognosis. Okay, next, let's talk for a moment about stress fractures. We did mention them briefly in the discussion of pars interarticularis stress fractures seen in hyperextenders, adolescent time frame generally. But there's a bunch of different stress fracture locations that are common around the body other than the pars. And this comes to mind when we see this case of a stress fracture occurring at the second metatarsal. And stress fractures are classically occult, and they often take some rest and re-x-ray to prove through callus formation that they're actually present. Of course, advanced imaging like MRI or bone scans would detect a occult stress fracture. But radiographically, typically the patient can kind of immobilize it, wait it out a week, and reassess. And that's really the mode of management that's most useful, particularly in like a high-level athlete. But March fracture is the name given generally to stress fractures occurring at the metatarsals. There are some stress fractures that happen at other locations around the body. So, for example, the golfer's stress fracture, which occurs at the ribs. Weightlifters very often get stress fractures at the upper ribs, 1, 2, 3. Trap shooters, the coracoid process can undergo a stress fracture. Anything with jumping can land with shin splints, which are kind of stress fractures at the tibia. So there's innumerable stress fractures around the body, but this is a very classic location, generally associated with new military recruits who start marching, in boot camp with a heavy, bag or heavy luggage and end up with a stress fracture in their metatarsals. Now here's an example of an acute fracture pattern that's really common to the foot, and this is generally an avulsion style fracture. And avulsions, we can always find the culprit, right? Like what muscle or, really tendon or ligament kind of ripped off the bone at that location. And the culprit in the case of Jones fractures is the peroneus brevis tendon. The peroneus brevis attaches at the base of the fifth metatarsal, something like this, and avulsion fractures can occur. Remember, these are always horizontally oriented and kind of go along the short axis of the bone, in contrast to the growth plate that can happen in young people in a longitudinal orientation. Not seen here, but sometimes, you have a pediatric patient who has a growth plate and they injure their foot and you're trying to decide, is it a fracture? Jones fractures always live horizontally across the base of the fifth metatarsal. Now here's kind of a stress-based injury, and there's a bunch of different of these around the body. So Osgood-Schlatters is one of them, and one of the more popular ones is a traction apophysitis, right? So an apophysis, attachment point of ligament or tendon to bone, causes inflammation when hyperextension, kind of in a repetitive scenario, occurs, and apophysitis to the tibiotuberosity can occur. So you'll notice here the tibiotuberosity, and that it almost looks like there's kind of a widened space between the tuberosity and the parent tibia. And realistically, the synchondrosis, or the cartilage that happens between the tibiotuberosity and the tibia, is really an extension of the tibial growth plate. And one of the challenges is the hyaline cartilage attachment with very strong pull of the quads. And you'll notice here there's some soft tissue swelling occurring. When making the diagnosis of Osgood-Schlatters, you need all the pieces to fit. You need the patient to have the right history, you need the patient to have pain and tenderness at that location, and also swelling radiographically. And that's the most important point, because through normal development, the tibiotuberosity can be quite fragmented, similar to the calcaneal apophysis. And so the appearance of the apophysis, unless it's avulsed, is really less sensitive to Osgood-Schlatters than the soft tissue swelling that should always be present over it. Remember, these are conservative management. The patient just rests and let it, feel better, and then they can get back to the activity. Now here's another example of a fracture pattern that can have some complications to it. And actually, when we talk about avulsions in general, complications include things like non-union, where the piece of bone just fails to reattach to the parent bone. And that's the case in this particular diagnosis. But at this location, the fracture that does not unite can hypertrophy and get larger. And these are called rider's bone. These are often seen in people who have a lot of hamstring action, so historically named after horseback riders, hence rider bone, but can be seen in things like cheerleading, hurdling, a number of activities where the hamstrings are heavily engaged, and this hypertrophic change to the avulsed piece is what we end up seeing. So they call these rider's bones. Ischiotuberosity location, really apophysitis and avulsion that ended up hypertrophying. Now, thumb base fractures. And when we talk about thumb base, we're really talking about the metacarpal base of the thumb. You'll notice there's a fracture here at the base. So there's two that occur here. One's Bennett and the other is Rolando. Bennett fractures are non-comminuted, meaning there's a single fracture line resulting in two pieces of bone from the one that fractured. So you'll note here one fracture line, two pieces of bone. This is non-comminuted. And at this location, it's called a Bennett fracture. There is a comminuted variety that we refer to as a Rolando fracture. So these are eponyms given to these fracture patterns. I'll just make a quick note that there's a number of fractures that have people's names associated with them. These are people like conditions too, like Paget's disease was named for Sir Godfrey Paget, you know. And so these are some things you'll want to remember for boards, mostly for the multiple choice component, but for the film test part, this is not usually a big feature of the test. Bennett versus Rolando, first metacarpal base. Now, metacarpals are commonly fractured locations in general, and typically they'll divide metacarpal fractures between like boxer and barroom fractures. So typically a boxer fracture is going to be seen along the second or third metacarpal heads with a properly thrown jab, right? But barroom fractures are typically what they're called when they involve the fourth or fifth metacarpal. So you'll notice in the image off to the left, a second metacarpal neck fracture. In the case off to the right, a fifth metacarpal neck fracture. And then we're always worried about the scaphoid, right? There's always a situation where the scaphoid is at risk for fracture. Remember, scaphoid fractures are the most common fractured carpal. And these are usually caused by fall on an outstretched hand. Now, the trickiness to scaphoid fractures is that they can be occult. And so there's a couple of scenarios that we think about when we heavily suspect a scaphoid fracture, but we're not sure. We should think about a P to A ulnar deviation view. We should think about an MRI examination or CT to show the fracture or the edema that comes with it. And so radiography can be quite deceiving. So these can go undetected initially, but the patient should have pain in the anatomical snuff box, right? Kind of painful and reduced range of motion, palpatory tenderness. And so there's some clinical picture to this. But here's an example of how you can barely see a scaphoid fracture. Like in this case, there's just a little suggestion of some cortical discontinuity there. In the image off to the right, I think we can more kind of frankly see the fracture line, but it's still faint and non-displaced. And so scaphoid fractures can be a little tricky, but remember, scaphoid is the most commonly fractured. There's a couple of forearm injuries. The Galeazzi, Montagia, and nightstick fracture. Those are really the three that involve the forearm. And what's unique about the nightstick fracture is it's an isolated mid-shaft ulnar fracture. It's like a person puts up their forearm in front of them to, protect themselves from being struck by a hard object. And they end up hitting the mid-shaft of the forearm, ulna, and it fractures along the diaphyseal location. There's a couple of AKAs. Well, really, there's one AKA the nightstick, AKA Perry fracture, like Perry Mason. And it's an isolated ulnar fracture. And this varies from Galeazzi and Montagia in that there's no associated dislocation at the proximal or distal ends. And so this is a really simple fracture pattern. Now, Galeazzi and Montagia are a little more problematic because they involve fracture and dislocation. I always use I can't even think right now, the acronym GRUM to remember what's fractured with Galeazzi versus Montagia. Sorry, I'm doing this with a mouse. So in Galeazzi injuries, the radius is fractured. And in Montagia injuries, the ulna is fractured. And then, of course, the other bone is dislocated. So let's start with the kind of image off to the left here. We'll notice that the ulna is fractured. So the line in the sand occurs here. GR versus UM. So in Montagia fractures, the ulna is fractured. That's the case here. And then you'll note the associated proximal radial dislocation. So radial head dislocation coupled with a mid-shaft ulnar fracture. You'll notice in the image in the middle, now this is a radial fracture. We know the G goes with R, Galeazzi, the radius is fractured, and then the ulna is dislocated distally. And you'll notice the dorsal displacement of the ulna on the lateral view. So Montague versus Galeazzi. Galeazzi is a more proximal injury, or excuse me, Galeazzi is more distal injury, and Montague is a more proximal injury. And then the Colles fracture and its variant. Colles is a very common fracture pattern seen on an outstretched hand, right? Usually an osteoporotic patient or an elderly patient that falls on an outstretched hand. Colles fracture is a very common variety. It's defined as a distal radial fracture with dorsal angulation of the fragment. So we'll note in the case off to the left, which includes a P to A wrist and a lateral wrist here off to the kind of right of that image. You'll notice the distal radius is fractured. It's really a metaphyseal fracture. But before we decide if it's a Smith or Colles, we have to note which direction the fragment went. So when we look on the lateral views, let's identify what's ventral. Remember lateral views, the thumbs kind of folded over. So this is the first metacarpal, which means this is the dorsal side of the wrist. Now when we look at the piece that's fractured, notice it's gone dorsal relative to the parent bone. Relative to the parent bone. That dorsal displacement confirms that this is a Colles fracture. Now, in the image off to the right, patient has a distal radial fracture. It's a little hard to see here, but notice on the lateral view that there's ventral angulation to the radial fragment. This is a Smith's, also known as reverse Colles. We know this is ventral because of the thumb, first metacarpal sitting ahead of the rest. This is the dorsum of the hand, so ventral malposition of the radial fragment, Smith. Now, here's a fracture pattern that's kind of a little old guy, but has a really profound impact on the integrity of the structures within the knee. The Sagan fracture, which is what this is a little avulsion fracture that happens on the lateral aspect of the tibial plateau at the insertion of the iliotibial band. And this is a little small fracture pattern, but the significance is that there's a really high association with meniscal tears and anterior cruciate ligament tears, like to the tune of like 75 to 100%. The image off to the far right is an MRI examination, or at least a T1 weighted slice through the ACL plane from that knee scan. And what usually should be very taut and linear low signal fibers to represent the ACL is just a jumbled iso-intense mess. This patient has an ACL tear associated with the Sagan fracture. Now the middle image is a tunnel view. Remember, this is kind of a flexed AP view, and you'll notice there may be some suggestion of some osseous density within the intercondylar notch here of the tunnel, and this may be material associated with the ACL tear. Generally avulsions off the tibial notch or the intercondylar notch, or sometimes the tibial spines are avulsed in cases of ACL tear. So here's an example of a Sagan fracture complicated by an anterior cruciate ligament tear. Just notice the lack of taut fibers. Here's an example of what tendinous and ligamentous fibers should look like, really low signal, taut, and linear. All right, let's get into the arthrotides. Here's the different arthrotides that we're going to go through.